this evening discussion, which is Young Nigerian Neurosurgeon Forum monthly webinar, usually the last Friday of the month, and about this time, 4 p.m. This evening we'll be having a part of our program, practice, which is not just cut, Every time we cut and cut and cut, but there are things that determine our cutting, and there's something that happen after our cutting. So this evening is going to be sodium homeostasis and the neurosurgeon. Anchoring this evening program will be Aminu Kano University Teaching Hospital residents, and our moderator is from University of Uyo Teaching Hospital. So on this note, I hand over to the moderator, Dr. Ndafia Ned Michael. Thank you very much. Hello, Dr. Ned.
Okay, I can hear you now, Dr. Debury.
Yeah, please, you are the moderator. You can take over now. Thank you very much.
Okay. Good evening, colleagues and senior colleagues. You're welcome to this month. Hello?
Yes, we can hear you.
Okay. Okay. Good evening, colleagues and senior colleagues. You're all welcome to this month's installment of the Young Nigerian Neurosurgeons Forum series of webinar. Today we'll be having this session, and the topic is sodium and the neurosurgeon. The subtopics for today will be physiology and pathology and the management of our common disorders related to sodium management in neurosurgical patients. I'd like to thank the executive members of the YNNF and our presenters today. First off, we have Dr. Migawa Kashim from the Aminu Kano University Teaching Hospital Kano as one of the speakers. And we also have Dr. Teslim Obayopo from Aminu Kano University Teaching Hospital equally as one of the speakers. And our faculty for today is Dr. Lakemi Badejo, a consultant at the University College Hospital Ibadan. All in all, you can be very sure we'll have a very robust and engaging discussion. Both presenters would have at least 25 minutes to make their presentation, after which our faculty for the day would take over. However, during the course of these, participants could feel free to drop questions in the chat box, and there would also be an opportunity to take live questions at the end of their presentation. Let me quickly recognize the presence of Professor Kumalafe in the house. Sorry, I'm just going to my chat now, and Professor Odosuti Kayode. Sorry if I mispronounce the name, it's not intended. You're all welcome, very senior colleagues, also faculty in the house. Can also see Professor Bankole in the house, Professor Abdullahi Jimo, and other very senior colleagues. Without much ado, I'd like to invite the first presenter for the day to get us well on our way. So, Dr. Migawa Ali Kashim.
In that place, there is occasional water issue. I'll not start looking for it.
Okay, sir. Thank you very much, sir.
Yes, please, you have the floor. Thank you
very much. Good evening, my teachers, consultants, senior colleagues, and colleagues. I'll be taking the first part of the presentation on sodium and the neurosurgeon, which will cover the physiology and pathology. So I will be using the following outline for my discussion. So sodium and volume are regulated by neural, hormonal, and renal mechanisms. And these systems integrate information regarding extracellular fluid osmolality, intravascular volume, circulatory hemodynamics, sodium and water intake. Though the regulation of sodium and water involves separate systems, they operate together. Sodium is the most abundant cation in the extracellular fluid. The total body sodium is 58 milliequivalent per kilogram, with a total exchangeable sodium of 41 milliequivalent per kilogram. The total intracellular sodium is 5.2 milliequivalent per kilogram, with total extracellular of 52.8 and total plasma sodium of 6.5. In the diet, sodium is usually expressed in grams of sodium ion, not sodium chloride. A low sodium diet is considered 2 grams of sodium ion per day or less. 1 teaspoon of table salt has 2.3 grams of sodium ion. 1 milligram of sodium chloride has 17 milliequivalent of sodium ion. Then 1 milligram of sodium ion has 43 milliequivalent of sodium. Normal saline has 0.9 grams of sodium chloride in 100 ml, while 3% sodium chloride has 3 grams of sodium chloride in 100 ml. Normal serum sodium concentration is kept between 135 to 145 millimole per liter. The serum sodium concentration is the main determinant of serum osmolality, contributing 90%. It is responsible for control and distribution of total body water. Changes in serum sodium concentration stimulate the addition or removal of water and therefore controls extracellular fluid volume. Action potentials, the basis of nerve signals, are generated and propagated by a rapid localized depolarization of the neuronal membrane due to the influx of sodium ions through voltage-gated channels. This depolarization then triggers similar events in adjacent membrane regions, causing the action potentials to travel along the axon. Neurons maintain a resting membrane potential of -70 millivolts, where the inside of the cell is more negative than the outside. A stimulus, usually a neurotransmitter or sensory input, can cause the membrane to depolarize at the axon hillock. When the depolarization reaches a threshold of -55 millivolt, voltage-gated sodium channels open. Sodium ions then rush into the cell, further depolarizing the membrane. Membrane potential peaks as sodium influx slows and voltage-gated potassium channels open, allowing potassium ions to flow out of the cells, restoring the negative charge. The membrane may temporarily become more negative than the resting membrane potential, called hyperpolarization, before returning to the resting stage. This propagation of action potential occurs due to the influx of sodium ions during action potential, creating a local current that spread along the axon, polarizing adjacent regions. In the area of the membrane that has just experienced action potential enters a refractory period, preventing immediate repolarization and ensuring the signal travels in one direction. In myelinated axons, the action potential jumps from one node of Ranvier to another, increasing the speed of propagation. It's known as, it is called saltatory conduction. While in unmyelinated axons, the action potential just propagates continuously along the membrane as each region is depolarized sequentially. Now, action potentials are all or none events. They either occur fully or not at all. They are self-propagating, meaning the signals travel along the axons without reducing. They are crucial for rapid communication within the nervous system and other excitable tissues like the muscles. This is a graphical representation of generation and propagation of the action potential. The sodium-potassium ATPase catalyzes the hydrolysis of adenosine triphosphate to adenosine diphosphate and uses the energy to extrude 3 sodium ions from the cell and take in 2 potassium into the cell for each molecule of ATP hydrolyzed. It is called an erotogenic pump in that it moves 3 positive charges of sodium out of the cell for each 2 of potassium into the cell. It is therefore said to have a coupling ratio of 3:2. It is found in all parts of the body and is crucial for establishing and maintaining the cell membrane's potential. This is a graphical representation of sodium potassium pump using ATP. Move 3 sodium into the extracellular space and 2 into cytoplasm. Sodium regulation is controlled via renal mechanisms that are influenced by both sympathetic innervation and natriuretic factors. Renal baroreceptors respond to sympathetic activation, hypotension, and or reduce sodium delivery to the distal tubule of the kidney by increasing the secretion of renin. Renin stimulates the production of angiotensin II. Angiotensin II not only stimulate receptors in the subclinical organ to induce test, but also stimulate a non-osmotic release of antidiuretic hormone. Angiotensin II also stimulates aldosterone synthesis. Aldosterone acts in the distal tubule of the nephron to promote reabsorption of water and sodium. Aquaporins also allow the kidneys to reabsorb water from urine and maintain hemostasis. This is a graphical presentation of sodium and water hemostasis with the renin, angiotensin, aldosterone pathway serving to cause sodium and water retention. And at the extreme end is the nephron of the kidney with antidiuretic hormone acting at the distal convoluted tubule and sodium and other cations being reabsorbed at the collecting duct. The natriuretic peptide family of arterial natriuretic peptides, brain or beta natriuretic peptide, and others promote natriuresis by inhibiting sodium reabsorption in the inner medullary collecting duct. And then they can also stimulate sodium secretion. They also inhibit renin, angiotensin, and antidiuretic hormone release. The osmolality of intercellular fluid and extracellular fluid are the same because most cells membranes allow free movement of water. Large changes in the extracellular fluid osmolality can result in water shifts, leading to cell shrinkage or swelling, which can alter cell function considerably. Solutes that do not freely close cell membranes, such as sodium and glucose, determine the tonicity of the extracellular fluid. This is a representation of what happens in hypotonicity, leading to cell swelling, and then if there's hypertonicity, cell shrinkage. The contribution of these solutes that are not permeable to the cell membrane to this extracellular fluid osmolality can be estimated with the equation displayed on the screen. Osmolality is a major determinant of water movement between extra and intracellular compartment, and it is maintained between 285 and 295 milliosmol per kg. Changes in extracellular fluid osmolality are usually as a result of an increase or a decrease in water volume, but occasionally it may result from a change in the amount of solute. Changes in osmolality are monitored by neurons in the hypothalamus called osmoreceptors. Then these are also related to the magnocellular neurons in the supraoptic and paraventricular nuclei of the hypothalamus and organ vasculosum of the lamina terminalis, where antidiuretic hormone is synthesized and transported to the posterior lobe of the pituitary gland. The magnocellular neurons also react to information concerning intravascular volume and pressure. Cardiac and vascular baroreceptors also detect blood pressure and volume variations and communicate information to the hypothalamus, such that hypotension or hypovolemia can lead to the release of antidiuretic hormone. This is a diagram showing the hypothalamus-pituitary axis. Now, this is a table showing the differences between osmoregulation and volume regulation. What is being sensed in the osmoregulation is the plasma osmolality against effective circulating volume in volume regulation. The sensors in osmoregulation, the sensor is hypothalamic osmoreceptors, while the carotid sinus, atria, and afferent glomerular arteriole are the sensors in volume regulation. The effector is the antidiuretic hormone, while for volume regulation, in addition to the antidiuretic hormone, other effectors include pressure natriuresis, natriuretic peptide, renin-angiotensin aldosterone, and antisympathetic nervous system. The effect in osmoregulation is either to increase water excretion via the effect of antidiuretic hormone or increase water intake via tests, while for volume regulation, sodium excretion is usually what is affected. Some functions of sodium in the body includes maintaining fluid balance, nerve and muscle function, blood pressure regulation, maintaining osmotic pressure, generating and propagating cell membrane potential, and then transport of nutrient as substrate across cell membrane. Some clinical significance of sodium includes high blood pressure if it is taken excessively, then dysregulatemia like hypo or hypernatremia. Then if the values are less than 240 or 321, they become clinically significant. With greater than 320, posing risk of renal failure. More than 340, causing stupor. Other details are shown on the screen. Also, high-frequency bursts of action potentials and hypersynchronization of neuronal populations can result in seizures. Also, local or regional anesthesia is used to block the conduction of action potentials in sensory and motor nerve fibers as a result of blockage of voltage-gated sodium channels on the nerve cell membrane. Now, I'll be going to the pathology. Abnormalities of serum sodium concentration are common in patients undergoing neurosurgery and those admitted to critical care with brain injury. Dysnatremia can be hyponatremia or hypernatremia. Disorders of sodium balance result from underlying systemic diseases. These diseases may include traumatic brain injury, subarachnoid hemorrhage, intracranial tumors, and in post-pituitary patients. Sodium abnormalities may also result from the inadvertent effects of treatment of these diseases. Abnormal serum sodium concentration, whether acute or chronic, increase morbidity and mortality in excess of the underlying pathology the patient is presenting with. Hyponatremia, it is the most common electrolyte imbalance. It is defined as serum sodium concentration less than 135 millimole per liter. It is seen in up to 15% of adult patients, often in older individuals. Hyponatremia is common after brain injury. It's seen in 50% of patients with subarachnoid hemorrhage, 15 to 20% of patients with traumatic brain injury, and 10 to 15% of those with brain tumors. It could be classified based on severity, duration, plasma osmolality, or extracellular fluid volume. Based on severity, it could be mild if it is between 130 and 135 millimoles per liter, moderate between 126 to 129, and severe if it is less than 125. It could be acute if it's less than 48 hours, or chronic if it's more than 48 hours. Then, based on plasma osmolality, it may be hyper, iso, or hypoosmotic hyponatremia. Now, the hypoosmotic hyponatremia, also called dilution hyponatremia, can be expanded based on the extracellular fluid volume. Maybe volume expanded hyponatremia, euvolemic hyponatremia, and then hypovolemic hyponatremia. Any disturbance may be secondary to impaired renal water excretion, excessive water intake, or sodium loss. The commonest cause of hyponatremia is brain injury, followed by syndrome of appropriate AH secretion, then cerebral solid-weighting syndrome. Other causes include hypocortisolism, severe hypothyroidism, overzealous treatment with desmopressin, and hypotonic fluid infusions. Patients may develop adrenal insufficiency with pituitary tumors and also craniopharyngiomas. Non-neurological causes include cardiac, liver, and renal disorders. It may also result from iatrogenic, long-term effects of medications like the anticonvulsant carbamazepine, sodium valproate. Hyponatremia is often seen with hypotonicity, but can sometimes be seen in isotonic and hypotonic conditions. Clinical features are caused by cerebral edema and raised intracranial pressure as water moves from extracellular to intracellular compartments, caused by differences in effective osmolality between the brain and plasma, each resulting in the dilution of sodium in the extracellular fluid. Shifts in water from the extracellular fluid into the intracellular compartment causes cellular swelling and can acutely increase brain volume, causing acute cerebral edema, which can lead to neurological sequelae, including death. Large rapid shifts can cause acute cerebral edema, which may even lead to herniation and brain death. Compensation of this acute increase in intracellular volume begins first by reducing intracellular potassium, which is a rapid adaptation, followed by a decline in the production of intracellular osmolyte, which is a slow adaptation. The pathophysiology of syndrome of inappropriate antidiuretic hormone secretion is not fully understood, but it is thought that hyponatremia results from renal water reabsorption, causing dilutional hyponatremia in a patient who is clinically euvolemic or even hypovolemic. The water retention is secondary to an increase in release of antidiuretic hormone. The common causes of syndrome of inappropriate antidiuretic hormone secretion include subarachnoid hemorrhage, intracerebral and subdural hematomas, brain tumors, meningitis, encephalitis, and traumatic brain injury. Cerebral salt wasting syndrome that was first described in 1950 may result from centrally mediated increase in renal sodium loss, causing hyponatremia. This could be due to a damaged sympathetic nervous system failing to support sodium reabsorption and stimulate renin release because of hypothalamic damage. Another alternative theory suggests that increased natriuretic peptide released centrally after injury acts on the kidney to cause increased sodium and water excretion. It is predominantly seen after subarachnoid hemorrhage, traumatic brain injury, also in patients with brain tumors, ischemic stroke, and TB meningitis. Though etiologies of both syndrome of inappropriate antidiuretic hormone secretion and cerebral salt wasting syndrome have been contested in endocrine literature, the suggestion is that there are variations of the same physiological process. That cerebral salt wasting syndrome may be syndrome of inappropriate antidiuretic hormone secretion with the proposed salt wasting on into undetected volume expansion. Neurological dysfunction is the principal manifestation of hyponatremia. This could be worsened by other disease processes or underlying conditions, especially in patients with condition is located intracranially. Patients in whom the serum sodium concentration is greater than 125 millimole are usually asymptomatic. Those with values less than 125 may have symptoms including headache, nausea, and depressed reflexes. Then complications of severe and rapidly evolving hyponatremia may include seizures, coma, respiratory arrest, brain stem herniation, and even death. For hyponatremia, it is defined as serum sodium of more than 145 millimole per liter, which results when in the ratio of sodium to water,
in this case where the man came to,
which favors less water and or more sodium. It is hyponatremia is defined as serum sodium of more than 145 millimoles per liter, which results when there is a shift in the ratio of sodium to water, which favors less water and or more sodium. It is less common than hyponatremia in neurosurgical patients or those with neurological disease. In most cases, patients with hyponatremia have had pituitary surgery, subarachnoid hemorrhage, or traumatic brain injury. Hyponatremia could be classified into mild, if it is between 146 to 149 millimole per liter, moderate between 150 to 159, and severe if it's more than 160. Some causes of hyponatremia include increased free water loss without adequate replacement, like in osmotic diuresis, a lack of circulating antidiuretic hormone, also called neurogenic diabetes insipidus, or an inadequate renal response to arginine vasopressin, nephrogenic, also called nephrogenic diabetes insipidus. Hyponatremia could also be a result of excessive sodium retention as seen in primary hyperaldosteronism, Cushing's syndrome, or with the administration of hypertonic solutions. Hyponatremia is caused by inadequate free water intake or excess water loss. It is rarely caused from excessive salt intake. In hyponatremia, an increase in extracellular fluid osmolarity promotes movement of water out of cellular compartments with resultant cell shrinkage. In rare cases, severe hyponatremia can result in brain shrinkage, which, if significant enough, could produce mechanical destruction of blood vessels and hemorrhage. This is a picture showing a normal brain in the middle. Then to my right, this is what happens in hyponatremia, which causes brain shrinkage. If it's severe enough, may disrupt the bridging dural veins, causing hemorrhage. To my left is what happens in hyponatremia, leading to cerebral edema. This could result in raised intracranial pressure, brainstem herniation, including death. Within several hours of rise in extracellular fluid volume osmolality, the brain cells begin to generate intracellular osmolyte to increase intracellular tonicity. This adaptation will promote the return of water into the intracellular space and return the cells to normal size. If a rapid decline in extracellular osmolality occurs once intracellular osmolality has formed, like in rapid correction of hypernatremia, the likelihood of harmful cerebral swelling increases. Hypernatremia can also result in seizures and coma, as it causes a significant osmotic gradient from blood to brain. This results in rapid movement of water from the central nervous system with cellular dysfunction and lowered seizure threshold. The severity of symptoms is correlated with the degree and rapidity of hypernatremia. If they are severe, if symptoms are within 48 hours, that's acute, and then if it's too severe, it can significantly affect morbidity and mortality. Some symptoms include thirst, lethargy, muscle weakness, seizures, and coma. Central diabetes insipidus is the most common cause of hypernatremia in neurosurgical patients. Another cause of hypernatremia may be repeated use of osmotherapeutic agents like mannitol, hypertonic saline, or concentrated sodium bicarbonate solution. Nephrogenic diabetes insipidus causes hypernatremia too. Then in diabetes insipidus, the mechanism to concentrate urine is disturbed. For cranial diabetes insipidus, it results from a failure of antidiuretic hormone release from the hypothalamus-pituitary axis. It is common after pituitary surgeries, surgery for craniopharyngioma, or brain injury. Pituitary stack transaction can lead to permanent central diabetes insipidus. But in cases of damage distal to this or to the posterior pituitary lobe, function may recover as antidiuretic hormone can be released from the median eminence. When central diabetes insipidus develops after brain injury, it usually reflects poor prognosis associated with severe cerebral edema. Cranial diabetes insipidus is seen after death using neurological criteria and has implications for organ donor management. In diabetes insipidus, the patient may be unable to sense or act on test or to exclude sodium. This results in hypernatremia, as seen in some patients after neurosurgery who will have reduced consciousness from their brain injury or from post-operative edema or sedation that is used to facilitate mechanical ventilation. They will be unaware of the sensation of thirst and be unable to increase oral intake. So these patients are extremely prone to severe hypernatremia. In conclusion, sodium regulation is complex and affected by both pathological conditions and neurosurgical intervention. Management of dysnatremia needs an understanding of the pathophysiology. These are my references. Thank you. I will now hand over to the second presenter to present the management.
Thank you very much, Dr. Kashim, for your presentation. Would now welcome the next presenter. Dr. Teslim Abayo.
So let me stop sharing my screen.
Thank you very much. Do well to do that.
Go ahead.
Yeah, Dr. Teslim, you have the floor, sir.
So good afternoon, our teachers here present, consultants, senior colleague, and my colleagues. My name is Dr. Teslim Obayopo. I'm presenting management of common disorders. This is my outline. From introduction to common etiologies of dysnatremia, I'll talk on hyponatremia and the common presentations hypernatremia, then compare the laboratory findings, then coming to management, perioperative management, risk, conclusion, and references. Introduction. Dysnatremia could be hyponatremia or hypernatremia. The management of hyponatremia often involves distinguishing between two complex conditions. It may occur preoperatively in neurological disease or following surgical procedures. Therefore, patients with normal sodium homeostasis should be monitored following surgical procedures that predispose to sodium dysregulation. The common etiologies of dysnatremia. Those causing etiologies of hyponatremia are syndrome of inappropriate antidiuretic hormone secretion and also cerebral salt wasting syndrome. Hypernatremia on its own develops from diabetic insipidus. Understanding the key differences between SIDH and cerebral salt wasting is crucial for accurate diagnosis and effective management. In the event of a wrong diagnosis, management is associated with high morbidity. Hyponatremia, caused by a syndrome of inappropriate antidiuretic hormone secretion. This refers to increase in release of ADH that is inappropriate to the serum osmolality, despite low effective osmolality and normal or expanded effective vascular volume retained in the extravascular and intravascular compartment, decreasing the concentration of sodium and other solids. SIDH is characterized by hyponatremia, serum hypoosmolality, urine osmolality, which is greater than serum osmolality, continued loss of sodium in spite of hyponatremia in the absence of renal disorder, and endocrine dysfunction. There is suppression of aldosterone secretion, resulting in disproportionate loss of sodium in urine, which further depletes sodium stored in the extracellular fluid. The common etiologies. SIDH commonly follows head trauma. It varies, incidence varies from 3.3 to around 33% of head-injured patients, particularly when it involves skull-based injuries. Encephalitis, meningitis, occurring with an incidence of 10 to 36%. Patients with TB meningitis are also predisposed to syndrome of inappropriate ADH secretion. Subarachnoid hemorrhage is commonly followed with syndrome of inappropriate ADH secretion. Brain tumors, even before surgery, commonly occur with SIDH. Post-surgery, patients are likely to come down with SIDH, particularly pituitary surgeries. Patients that are involved, that are on medications. Patients that are on chronic use of anticonvulsants, patients that are on antipsychotic, patients that are on chemotherapy drugs are prone to SIDH. What are the symptoms? Usually, symptoms, patients are asymptomatic. However, they could present with increased thirst, lethargy, patient could be restless, there could be confusion or coma. Also, patient could have irritability, personality changes, anorexia, or convulsion. There's also symptoms of fluid overload. Patient will present with facial swelling, pedal edema. There may be shortness of breath. There may be elevated temperature, or patient will present with features of imminent heart failure. Symptoms are more severe when the reduced level of sodium occurs within 48 hours. For cerebral salt wasting, while SIDH is typically associated with euvolemia or slight hypervolemia, cerebral salt wasting patients present with hypovolemia, and this is due to increased salt and water excretion. Cerebral salt wasting syndrome is characterized by hyponatremia, volume depletion, and elevated urine sodium excretion. The etiologies will be subarachnoid hemorrhage, commonly present with syndrome of cerebral salt wasting. patient with traumatic brain injury, patient with brain tumors, patient with hypoxic ischemic encephalopathy, patient with TB meningitis, usually present with cerebral salt wasting. Symptoms include polyuria, increased thirst, lethargy, agitation, headache, alters consciousness, seizure, and coma. Patient also present with symptoms indicating dehydration, dry mucous membrane, decreased spleen turgor, tachycardia, orthostatic hypotension. The primary key differentiator between SIADH and cerebral salt wasting lies in the patient extracellular volume status. Both conditions cause hyponatremia, but the treatment approaches differ significantly based on the distinction of a different volume status. The common cause of hypernatremia. The commonest cause of hypernatremia is diabetic insipidus. It is due to insufficient ADH activity in the kidney and results in excessive renal loss of water and electrolytes. It's usually of two types, the central or neurogenic DI, which is commonly experienced by neurosurgeons, and the nephrogenic diabetic insipidus. It usually occurs following pediatric surgery. Commonly after pediatric surgery, one of the first complications we watch out for is diabetic insipidus. It is also seen in patients with metastatic brain tumors. Patients with hypoxic or ischemic encephalopathy also present with diabetic insipidus. Patients on radiation for brain pathologies. Patients with infection, meningitis, encephalitis also come down with diabetic insipidus. For following following pituitary tumor surgery, diabetic insipidus could be transient, in which case it occurs in the first 2 to 16 hours and resolves. It could be prolonged. It could extend to months or weeks, and also it could be triphasic, in which there is an initial excessive urine output, followed by a normalized urine output, then also followed by a third phase, which is excessive urine output. The first phase is a result when there is an insult to the hypothalamus pituitary axis. There is reduction in the blood level of ADH, will result in excessive urine secretion. However, when the cells degenerate and die, intracellular ADH are released to the system. The ADH helps to normalize urine output. Then when the ADH released are consumed and there are no more cells to release ADH, patient comes down back with diuresis, which may be uncontrollable. Symptoms: patient present with polyuria, excessive thirst, weakness, irritability, restlessness, and it progresses to lethargy, coma, and death. Then there are signs of dehydration, dry mucous membrane, decreased skin turgor, tachycardia, and orthostatic hypotension. The management of sodium dysregulation. Management will be perioperative, which involves history taking, examination and investigation the patient, then the treatment. For syndrome of inappropriate antidiuretic hormone secretion, most patients are asymptomatic. However, in preparation for surgery, the first indication of sodium impairment is when we get results of sodium electrolytes. When we notice there is a decrease in sodium, serum sodium. Patient may present with irritability, restlessness, muscle weakness, nausea, vomiting, and confusion. There will be history of road traffic accident with loss of consciousness and CSF leakage, indicating skull-based injury, which could have affected the hypothalamus pituitary axis. There may be history of fever, headache, and neck stiffness in patient with meningitis. Patient may present with headache, photophobia, and neck stiffness when there are subarachnoid hemorrhages. There may be seizure, change in personality, and limb weaknesses when there are patients present with brain tumor. Patient may be a known seizure disorder that is on anticonvulsants. And anticonvulsant is a predisposing factor. Patient may be on antipsychotics. The patient may be a cancer patient that is on chronic chemotherapy medications. There may be use of diuretics particular patients being managed for imminent heart failure, or patients that are on antihypertensive. Then also in the management of head trauma, prolonged or irrational use of mannitol can predispose patients to SIADH. In examination, patient will be maybe alert or confused or lethargic. Usually, patient may also be restless and irritable. Because of fluid overload, patient may have facial puffiness, weight gain, and pedal edema. Patients that are on chemotherapeutic dose usually notice alopecia. Investigations include serum and urine osmolality, urine sodium and urine specific gravity. They can be done bedside. We also can request for electrolytes, urea and creatinine to give us an impression of presence of renal impairment or not. It also gives us serum sodium, serum potassium, which is also a dysregulating factor in sodium regulation. As one of our hypokalemia is a risk factor for impaired response of the kidney to ADH. We can also do a full blood count with differentials to rule out anemia. Anemia, especially iron deficiency anemia, are known to go in line with hyponatremia. In fact, severe iron deficiency anemia would go along with severe hyponatremia. We also test for serum calcium. Hypercalcemia impairs the response of the kidney to ADH. It also can result to hypercalcinosis, which also damages or impair the kidney physiology and function. We can also request for brain images, CT scan, MRI, to rule out intracranial lesions that may be the culprit for the SIADH. For cerebral Salt-Watson syndrome, patients present with thirst, polyuria. Also, patient, because of the excessive, the hypovolemia, patient may present with signs in keeping with dehydration. We also have to check for the artery. Patient may present with tachypnea. Patient may be hypertensive. The cerebral venous pressure is the gold standard. It measures it helps in keeping track of the venous return or the fluid status of the patient. For diabetic insipidus, patients usually present with polyuria and polydipsia, usually following surgery. There's also tests. And also we have to rule out tumors in other parts of the body that may, because one of the culprits is metastatic or primary brain lesions. There may be history of trauma with severe blood loss. There may be also history of radiotherapy. It's also a predisposing factor to diabetic insipidus. The table above tells us the diagnostic criteria for each of the pathologic entities. For syndrome of inappropriate ADH secretion, there is, after laboratory investigation, there is hyponatremia of less than 135 millimole per liter. There is low serum osmolality of less than 275. There is increased urine osmolality, usually more than 100. Then so there may be normal or elevated serum urine sodium. Then urine output is reduced because there is retention of fluid. Specific reactive is also tested is 1.01. Then also there is increased intravascular volume. There may be normal serum urea. For cerebral Salt-Watson syndrome, there is hyponatremia, just like SIADH. There is low serum osmolality. There is elevated urine osmolality also. There is also elevated serum sodium. Urine output is decreased because there is hypovolemia. So urine specific gravity also is increased. Then also serum urea is elevated also. Then patient can usually present with postural hypertension. Then for central diabetic insipidus, there is elevated serum sodium above 145 millimole per liter. There's elevated serum osmolality above 295. There is reduced urinary osmolality. Also, there is maybe normal or reduced urine sodium. And also urine output is always increased because there is uncontrolled fluid loss. Then also patient there's reduced body weight and patient may be tachycardic. So that tell us the different clinical presentations of or laboratory results that we get from during investigation. Water deprivation test. This is used to diagnose the different type of diabetic insipidus. They are conditions characterized by excess thirst and excess urination, excess fluid loss. In other individuals, the kidney effectively concentrates urine when fluid intake is restricted. In that case, there is a rise in urine osmolality and there is a slight increase in blood osmolality. In individuals with central diabetic insipidus, the kidney cannot concentrate urine despite water deprivation, resulting in low urine osmolality. In individuals with nephrogenic diabetic insipidus, the kidney is unable to respond to ADH, leading to a low urine osmolality even after water deprivation. And after deprivation, we can also confirm by giving external desmopressin to distinguish between central diabetic insipidus and nephrogenic diabetic insipidus. After the administration of desmopressin, in nephrogenic diabetic insipidus, the response is abnormal. The kidney fails to concentrate urine. However, in central central diabetic insipidus, after the administration of desmopressin, there is normal urine osmolality. Treatment of dysnatremia. It is of importance to note that the treatment of dysnatremia is multidisciplinary, involving the neurosurgeon as the lead, the neuroanesthetics, instances where patient has to be admitted into ICU, the endocrinologist, they has to monitor endocrine abnormalities, and also the nephrologist, because there could be the kidney could be culprit. In treating SIDH, it is important to differentiate between SIDH and cerebral salt wasting. Also, we have to avoid too rapid correction and overcorrection to reduce the risk of osmotic demyelination syndrome. Then, depending on the severity of the symptoms and the laboratory findings, there are different treatment protocols. For patients that are asymptomatic or non-severe hyponatremia, or severe hyponatremia that has occurred that is chronic, the first fluid restriction. Patient is made to take fluid not more than 1 liter in 24 hours, or maximum of 1.5 liters. Then also we can institute dietary salt intake without commencing normal saline. You give 1 teaspoon of salt is known to contain 2.3 grams of sodium. So that can give us an estimate of how much salt we are given during correction. For patients that are symptomatic, or they have non-severe hyponatremia, or they have severe hyponatremia that is chronic, or they have moderate non-specific symptoms, we can commence normal saline infusion at normal maintenance dose, 1 liter 8 hourly. We can also give furosemide in order to prevent fluid overload. And also do serial monitoring of serum sodium, usually every 4 hours. The target is to increase serum sodium by 0.5 to 0.2 millimole per liter every 1 hour. For patients that have severe hyponatremia, or hyponatremia that is occurring in less than 48 hours, or they're having severe symptoms, seizures and coma, first is to transfer the patient to the ICU and institute neurocritical care. Then we commence hypertonic saline. It is given at 1 to 2 ml per kg per hour. or in severe cases, we can increase the dose, or we can give a shot of 150 mils of 3% saline over 20 minutes. Then we'll do a serial sodium monitoring. In order to prevent fluid overload, we give IV furosemide 20 milligram 6 hourly. The target is to raise serum sodium by 1 to 2 milliequivalent per liter every 1 hour, or patient becomes asymptomatic. Once seizure has stopped, patient is gaining consciousness, that's the target. Then also, when we achieve a serum sodium of 130 millimole per liter, then we can also target increasing serum sodium by 10 millimole per liter in 24 hours or 25 millimole per liter in 48 hours. We should also monitor the serial serum potassium monitor, because hypokalemia is a predisposing factor or impairs the response of the kidney to ADH. If targets are not achieved, we can commence medications. We can give patient dimethyl. It is an anti-ADH. It impairs, it inhibits adenylyl cyclase, which is involved in the response of vasopressin and aquaporins. We can also give vaptans. Vaptans are vasopressin receptor inhibitors. They bind to, they impair the response of aquaporins to ADH. In treating cerebral salt wasting, the most important treatment is volume replacement. We have to strive to achieve euvolemia. We can also, you can do that by commencing crystalloids, usually normal saline at normal maintenance of 1 liter 8 hourly. For severe cases, we can institute hypertonic saline at 25 to 50 mils per hour. Then we can commence supplementary salt intake. And of note is there's no room for fluid restriction, no room for use of furosemide. The target for cerebral salt wasting is the same target for SIDH. And if target is not met, we can commence patient on hydrocortisone. It's a corticosteroid that has mineralocorticoid activities. It helps in the absorption or retention of sodium in the kidney. Then also fludrocortisone also has similar mechanism of action. It is given at 0.2 milligram IV or per oral 6 hourly. For diabetic insipidus, the main treatment is strict fluid balance. In conscious patients, oral intake suffices. We ensure that patients, as much as is passing out in urine, is taken orally. For patients that are obtunded or patients that are conscious but have impaired thirst mechanism, we ensure a strict hourly urine input and output and ensure a replacement of fluids meal per meal. We can also pass NG2 to enhance fluid replacement. In instances where serum sodium is above 155 millimole per liter, we can commence 5% dextrose. And as we're doing that, we do a serial monitoring of serum sodium, preferably every 4 hours, and also monitor urine specific gravity forwardly. In a diagnosed diabetic insipidus, usually when urine output exceeds 250 mils per hour for patient post-op, we can commence desmopressin. It's a long-acting vasopressin which binds to vasopressin 2 receptors. It's usually given as nasal spray at 10 to 20 microgram, or we can also give IVIM subcutaneous 1 to 2 microgram BD, or it is also given orally. Risk and complications. In the correction of hyponatremia, a patient can develop osmotic demyelination syndrome. Complication associated with some treatment of hyponatremia, while excessive slow correction of acute hyponatremia is associated with increased morbidity and mortality, overzealous treatment can be associated with osmotic demyelination syndrome, one of which is central pontine myelinolysis. It is noticed by insidious onset of flaccid chorophagia, mental status changes, and cranial abnormalities. Patient can also develop hyperchloremic acidosis because of continuous and prolonged use of sodium chloride. Excessive chloride accumulates within the intravascular system. It is associated with normal 2% saline, and it's a metabolic acidosis that augments inflammatory responses, decreasing renal cortical blood flow. It reduces gastric mucosal perfusion, causes tachypnea, hypocapnia, and as a result, the risk of cerebral vasoconstriction. Another complication is fluid overload during fluid replacement. In conclusion, the management of dysnatremia involves identifying and treating the underlying cause, distinguishing between hypo and hypernatremia, and distinguishing between these two and the two causes of hyponatremia. Then also it should of note that misdiagnosis is associated with high mortality. These are my references. Thank you.
Thank you, Dr. Tessin Bio, for your presentation. Well researched, well thought, and well presented. I will now move on to the other segment of this webinar. Before I proceed, I would like to give indulgence of the House to recognize very senior colleagues of the profession who are here present. I'd like to acknowledge the presence of Professor Edward Komolafe, consultant neurosurgeon from the Bafemewolowo University Hospital, Professor Abdullahi Jimo, consultant neurosurgeon from the Ahmadu Bello University Teaching Hospital Zaria, Professor Olufemi Bankole, consultant neurosurgeon, also the chairman, the president of the Nigerian Academy of Neurological Surgeons, Professor Okeje Kanu, consultant neurosurgeon at the Lagos University Teaching Hospital. And I would also like to specially recognize the presence of Dr. Katunga Diumexi Kabulu, the co-chair of the Young African Neurosurgeon Forum from Jensen Twende General Provisional Hospital in DR Congo. We also have Dr. Banson Mabel from Kolebu Teaching Hospital, Ghana, Dr. Bryson Mutama from Zimbabwe, and Dr. Mbusa Kasuba from Uganda. Now would like to take questions and contributions from our teachers, our trainers, foreign colleagues, and other members on the platform. The floor is open for questions before we take the contributions from the faculty of the day. Questions could also be dropped in the chat box, and they would be promptly read out.
Hello.
Okay. Yes, good day.
Thank you very much to the presenters for a good effort at talking about something that is quite interesting and complex at the same time. I just wanted to highlight to the young surgeons here about the intricate and delicate nature of dealing with these two problems that are interrelated, hyponatremia and hypernatremia. I want to use an index case that we had a patient who had preoperative hyponatremia, and we took time to correct the hyponatremia. And when everything was normal, we took him to the theater. Surgery was done, but immediately post-op, we were faced with malignant and recalcitrant hypernatremia, which probably could have been related to the efforts at dealing with the hyponatremia pre-operatively. So while we talk about the conditions and talking about how we need to correct them, we need to also be aware that they can actually trap you in the middle. So while you are correcting hyponatremia, it's probably important for you to take time after achieving normal serum levels and monitor the patient and see his progress before rushing into the theater, just to avoid what we went into. A preoperative hyponatremia, which was resolved, and we were quick to take the patient into the theater, and we ended up with a malignant hypernatremia post-op that never responded to therapy at the end of the day. Thank you very much.
Thank you very much for that contribution. I think every neurosurgeon would have become quite conversant with the dilemma in managing sodium derangements in neurosurgical patients. I'm sure as the discussion progresses, we would have more of these issues brought to the fore and thoroughly discussed. The question from the chat box. Thanks for your effort at discussing an important topic that's open. I have often said that sodium is either a friend or enemy of the neurosurgeon, depending on the level. The question was, how do you discover, diagnose, and manage osmotic demyelination syndrome, previously called central pontine myelinosis? Thanks once again for your presentation from Professor Okezie Kanu. I think that will be the attitude Dr. Teslim Obayopo. Is it Teslim?
Hello?
My brother.
In the management of SIDH, once we diagnose osmotic demyelination syndrome, we stop the management. Hello? Can you hear me?
Yes, you can hear it, sir.
Yes. First, it is better prevented than managed. And once it is diagnosed, confirmed, first is to stop the management intervention we are putting, which is salt replacement. We can now give, from what I came across, we can give fluids that will reduce the level of sodium in the system in order to perhaps reverse the damage that has been done, which is the demyelination. However, it is better prevented than managed. Thank you very much.
Thank you. Another question in the chat box. Kindly describe the water deprivation test. And then in a resource poor environment where regular checks are not feasible, how do you ensure that sodium correction remains within acceptable ranges when managing severe hyponatremia? You could do well to take a shot at this.
In the water deprivation test, first the patient is put on all fluid that stopped, and the patient is put on nail power oral. Then we monitor, we do a serial urine osmolality monitoring every 1 hour. Then for patients that have normal responses that are not having DI, the urine osmolality at a point rises to between 600 and 850 milliosmol per liter. Then as we continue the serial monitoring, the value plateaus, variations around less than 30 milliosmoles per liter. However, the value stays constant. That shows that the system or the patient has the capacity to regulate fluid loss or reduce fluid loss in the face of fluid deprivation. And also, if you want to distinguish between central and nephrogenic DI, endogenous ADH is administered. For patients that have central diabetic insipidus, because we are replacing the ADH that is not in system, there is normal response, meaning that patients achieve normal urine osmolality. However, for patients that have impaired, that have abnormal response, or patients that have nephrogenic DI, despite administration of ADH, patient continues to pour water, which is evidenced by persistent low urine osmolality.
Okay, the next question is, are there yeah, good enough. The next question in the chat box is, are there anesthetic considerations in managing patients with sodium electrolyte imbalances or sodium imbalances rather? Hello?
Hello?
Yeah. Okay, let me just go to the question once more. Okay, yeah, sorry about that. Are there anesthetic considerations in operating neurosurgical patients with neurosurgical emergencies who have hyponatremia? And then how do you differentiate dipsogenic DI from other forms for water deprivation tests and contraindications?
Yes, patients that have hyponatremia, even pre-op, they may not be symptomatic, but we can predict they can begin to show symptoms prior to surgery, even during surgery, and which may not be noticed by the anesthetics or may be accepted as normal intra-op routine. So it is essential to correct hyponatremia before we take patient in for surgery. Because symptoms may come up and it will be masked by the anesthetic state.
Thank you very much. If I can add something in relation to anesthetic considerations, when you are dealing with a patient with hyponatremia in emergency circumstances, yes, of course, I think that's the time when you need to really sit down and talk with the anesthetist about what you have in your hands and then discuss how the anesthetic medications are going to affect the condition you are dealing with. As I have come to realize later, a lot of the anesthetic medications we're taking for granted actually alter to some extent the hemostatic levels of sodium and potassium. So you need to speak with them, all the drugs they are going to use, you should make sure that they're not going to worsen the hyponatremia that is pre-existing. And most importantly, the fluid administration also has to be strictly monitored, and the choice of fluid has to be made vis-a-vis the hyponatremia you're already dealing with. Because intraoperatively, the fluid administration is entirely in the hands of the anesthetist. So if he is not aware of the hyponatremia that is existing, chances are he may use fluids or he may use quantity of fluids that may end up worsening the state of your patient. And by the time you finish a successful surgery, clean surgical field, you have a patient that will not wake up. So I think it's very important if you are dealing with a patient with hyponatremia, you sit down with the anesthetist and have an extensive discussion, discuss all the drugs he's going to use, his choice of fluids and the quantity of fluids that he's going to use through the in the perioperative period to avoid very bad outcomes at the end of the day. Thank you very much.
Wow, I don't know if I can contribute. I asked that question because there may be need for we to intervene when we have some emergencies in which we cannot wait for 48 hours or so to be correcting hyponatremia. So consideration, as Dr. Misbauer have already said, is very germane, fluid and electrolyte. Another issue with your hyponatremia is cerebral edema. So the raised intracranial pressure and medications that could, or technique that could worsen the intracranial pressures, raise the intracranial pressure, also needs to be discussed, and measures to bring down intracranial pressure, because the net effect is for the patient to be able to come out of surgery so that you can continue post-operatively, continue to manage such hyponatremia. Thank you, Ms. Bauer. So most of the things you said was what I wanted to say. So that was the reason why I asked that question. Thank you.
Thank you, Dr. Egosa Morgan and Dr. Misbah, for your contributions. I don't know if there would be any other questions or contribution before we invite the faculty for the day. Yes, Dr. P.D. Didamson, you have the floor, sir.
Okay, sir. Thank you very much, sir, for the opportunity. Thank you, presenters, for the presentation. I'm Dr. Didamson from Zaria. I want to ask, is it possible to use a peripheral line for when you are using hypertonic saline like the 3%? If yes, what are the precautions that can be taken? Thank you.
Okay, Dr. Teslim, in addition to that, yes, Dr. Teslim, in addition to that, there's a question in the chat box. Is there a relationship between steroid use and sodium homeostasis?
During sodium replacement for using hypertonic saline, it is best to use a central line because ease of delivery, measured delivery, and also the risk of causing peripheral venous inflammation. So it's best to use a central line. So that is that. That is that. Then steroids. Steroids will essentially what they do is to reverse natriuresis. They enhance the reabsorption of sodium along with some water back into the intravascular system. So that is why it is one of the things that is used when we want to correct hyponatremia. We use hydrocortisone or fluorocortisone as a medication to correct hyponatremia. It has, even hydrocort has mineralocorticoid effects that cause reabsorption of sodium into the intravascular space. I don't know if that answered the question.
Then another
Yes,
question in the chat box.
Hello, sir.
Okay, yes, please go ahead, sir.
Yes, sir. Okay, so it is possible actually to use a peripheral line for the hypertonic saline. However, it has to be like in emergency situation where the patient does not have a central line. But it has to be the larger peripheral vein that you can find. And then also the patient has to be monitored for the features of extravasation or thrombophlebitis that could occur before the central line can be secured, and then you now continue with the hypertonic saline. Thank you, sir.
Thank you very much for your contribution. The next question is, thanks for your presentation. How easily do you access hypertonic saline? Any considerations when correcting hyponatremia in pediatric patients? And then what's the difference between serum osmolality and osmolarity? You have the floor, sir.
Thank you very much. In fluid correction in pediatrics, we have to note that they are more predisposed to fluid overload. So we have to monitor closely and monitor the patient for signs of fluid overload when correcting. Then also hypertonic saline, 3% is not common in our environment. So what we commonly use is usual 0.9% normal saline. It's not a common fluid just in this environment. I've not seen one used. Then the last question.
Okay, just the difference between serum osmolarity and serum osmolality.
Osmolality is the amount of the solute, for in this case the salt, that is in a particular quantity of water. For instance, we can say we have 25 grams of sodium in 100 grams of water. That will be 25 over 100. But osmolarity is the amount of the solute in a particular quantity of the solution. So in the case of 25 grams of salt and 100 grams of water, our osmolarity will be 25 over 125. So that gives us the difference. Osmolality is the amount of solute in a particular quantity of the solvent, but osmolarity is the amount of solute in a particular quantity of the solution. Thank you very much.
Hello, sir.
Please go ahead.
Yes, sir. Okay, I just wanted to add to the accessibility to hypertonic saline. Actually, we have used it in Zaria, but we had to collaborate with a pharmaceutical company in Abuja, and they were able to get it for us, and we use it for a patient. So it's possible if you liaise with some of these pharmaceutical companies, they can get it across to us. Thank you, sir.
Thank you very much.
Thank you very much for that. I think that solves one big problem with who to call out or who to call on rather for help with hypertonic saline. I've had that challenge in practice. I think that information is very handy. And the next question is, thanks for your presentation. What happens when chronic hyponatremia becomes a calcitrant without symptoms and the anesthesiologist refuses to take your patient for surgery? I guess the patient has a huge bifrontal tumor. I think there's more of a dilemma. What would be your take on this, sir?
Calcitrant hyponatremia. I think in recalcitrant hyponatremia, first we're trying to correct the hyponatremia and it's not responding. We should look at other serum electrolytes. We may be having dysregulated level of magnesium. Usually, hypomagnesemia may impair in the correction of poor abnormal sodium or abnormal potassium in the serum. So that's one thing we can do. I think that's as much I can talk on that.
Okay, Dr. Obiagu, do you have any further comments on this?
No, Chief, I don't have any further comments. I just wanted to have your own opinion.
Thanks for that. Then the oh yeah, just taking it right off the top of my. Can we get the contact of the pharmaceutical company, because I have challenges getting it in our center and get that much hypertonic saline. So the doctor would do well to probably drop the contact in the chat box. Like I said, I had sourced for this and it was almost impossible to get it at short notice when I really needed it. So you could do well to drop the contact so that we all could make use of that venue. Thank you very much. If there aren't any other questions or contribution, I would like to now proceed to the next segment of this presentation, which would be to introduce the faculty for the day. And I will do that with a great sense of humility and service. Our faculty for today is Dr. Oluwakemi Badejo. She is a neurosurgeon, graduated from the College of Medicine, University of Ibadan in 2004. She completed her neurosurgical residency training at the University College Hospital Ibadan, earning the fellowship of the West African College of Surgeons in Neurosurgery in April 2015. She was subsequently appointed a lecturer at the College of Medicine, University of Ibadan in December 2015, and an honorary consultant to University College of Ibadan shortly thereafter, and has made significant contributions to both academic and clinical neurosurgery in both institutions. Research focuses in developmental neurobiology and experimental hydrocephalus, while her clinical interests are in vascular and pediatric neurosurgery. She is the coordinator of the neurosurgical postgraduate training at University College of Ibadan, where she has trained several neurosurgeons residents jointly with 5 other senior consultant neurosurgeons. She has also served as a mentor to undergraduate medical students, especially those with inclinations towards the neurosciences. She is the current co-chair of the vascular section of the Nigerian Academy of Neurological Surgeons and the chair of Women in Neurosurgery, Nigerian Academy of Neurological Surgeons. She is also involved in international global neurosurgery research collaborations aimed at training multinational medical students in research and advancing neurosurgical service delivery and policy making in sub-Saharan Africa. She has several academic publications, and she is a recent recipient of the prestigious Wins Greg Wilkins Barrick Chairs Visiting International Surgeon Award of the American Association of Neurosurgical Surgeons. Outside neurosurgery, Dr. Oluwakemi Badejo enjoys spending time with her family, and it doesn't subtract from the occasion to say she also enjoys spending time with her colleagues like she would do today, serving as a faculty for today's webinar. May I kindly invite Dr. Kemi Badejo to take over and perform our duties for today. You're very much welcome, ma.
Thank you, Dr. Duga. Thank you for having me. I'll just make a few comments and which would serve as take-home points and management pearls from this presentation. But firstly, I must say that I'm highly impressed with the scope and the depth of presentation by the presenters. And that's Dr. Kashin and Dr. Obayo, and also by the level of engagement by the audience. I would go on to the comments. So first of all, we should all note why this presentation. Fluid and electrolyte management are important aspects of the care of the neurosurgical patients, and disorders of sodium balance are commonly encountered in neurosurgical practice. Sorry, can you hear me? Okay, so commonly encountered in neurosurgical practice, and may involve too high sodium levels, too low sodium levels, values have been given by presenters. Should note that hypernatremia is usually associated with diabetes insipidus and may follow pituitary procedures, whether cranial or transsphenoidal, and proper management of post-op sodium derangement may be the determinant of a patient's survival post-operatively, a neurosurgical patient survival post-operatively, regardless of the dexterity or careful attention to details by the surgeon, regardless of how many hours the surgeon spends. Post-op electrolyte management is crucial to a patient's survival. We should also note that a surgeon cannot work in isolation, and every member of the neurosurgical team needs to be familiar with commonly encountered electrolyte derangements. And this would involve the neurocritical specialists and nurses, the ward nurses. They need to be well trained to recognize all of the things we discussed and giving clear instructions in the post-op order. Regular review of the post-op patient is also crucial. Like Dr. Obayoro mentioned, when you're managing replacement of excess fluid loss in diabetes insipidus, it's important to use hypotonic solution. Usually, like you said, in our center, we use 5% dextrose water. The patient is losing water, and if you give normal saline or hypertonic saline, you can worsen the hypernatremia that these patients have. Also, regarding hypernatremia, as was discussed, you can find it in diverse clinical scenarios, from trauma, note traumatic brain injury, to neuro-oncology, note brain tumors, to congenital anomalies, note hydrocephalus, infective causes, brain meningitis, encephalitis, brain abscess, to iatrogenic causes and vascular causes, of which subarachnoid hemorrhage is one of them. And it is important to know your hyponatremia. What are we dealing with? The second presenter gave us important pairs to differentiate between a cerebral salt wasting disease and a syndrome of inappropriate ADH secretion. And we should note that following subarachnoid hemorrhage, hyponatremia may be either from a syndrome of inappropriate ADH secretion, aka the short-batter syndrome. Well, we love a lot of eponyms in medicine. So for the part 2 residents, if you find short-batter in your exams, it's still SIDH. Okay, SIDH, quite different from cerebral salt wasting disease. Remember, we said that in cerebral salt wasting disease, you have an inappropriate ADH secretion in the absence of a physiological stimulus for this. However, in cerebral salt wasting disease, there's an actual natriuresis, an actual renal loss of sodium secondary to an intracranial pathology. And it's important to differentiate these two clinical scenarios, as fluid restriction, as mentioned, in a patient with cerebral salt wasting disease may have lethal outcomes, whether it's worsening the vasospasm-induced delayed ischemic neurologic deficit or tipping the patient into renal failure. And we should also note that the patient can switch from one form of hyponatremia, of sodium derangement, to another, whether it's switching from SIDH to CSW or even to hypernatremia. And so it is important to follow up your patients clinically and also with lab workups post-operatively, so that at each time you know what you're dealing with. Lastly, do not be too aggressive or overcorrect hyponatremia, as mentioned by the presenters, to avoid osmotic demyelination. In all, I've thoroughly enjoyed listening to the presenters. Thank you. Dr. Kashim. Thank you, Dr. Obayoro. Thank you, everyone, for having me.
Thank you very much, Dr. Oluwakemi Badejo, for that well-packed summary. And with that, I can say that the take-home for the webinar today is loaded. I'd like to also appreciate everyone who's kept faith with us since the beginning of the presentation up to this point. Special thanks again to our trainers and very senior members of the profession and our friends from other regions of Africa and other parts of the world who also made the date and had made this presentation quite engaging. I'd like to thank everyone at this point. I'd also like to thank the executive committee of the Young Nigerian Surgical Forum for maintaining this and having chosen a topical subject as this for discussions today. I very well hope that one of the greatest benefits we've had today has been pointing out, the peculiarities in management of the different derangements of sodium and the entities, and more so, I think we've been able to solve the problem of access to hypertonic saline today. All in all, it's been a very engaging discussion. And I think the amount of questions, comments that we've had is reflective of how common and how impactful sodium derangements are in the management of neurosurgical patients across the areas of subspecialization in neurosurgery. Sorry about that, I was logged out. I'd like to kindly hand over to the YNNF executive to take over. But just before I do that, let me kindly apologize to Dr. So I'm trying to scroll to see the comments. Got this up. Let me kindly apologize to the doctor who made the last comment in the chat box. So I didn't see that before now. Your comment is well noted, sir. So I would like to hand over to Dr. Gugadun to take us to the closing formalities for this webinar session. Thank you.
Thank you very much, Dr. Ned. Dr. Guga.
Okay, thank you. Thank you, Dr. Ned. Thank you, Dr. Adeboye. Kindly excuse me that my video isn't on. I'm in an open space. Actually, it might be inappropriate on my video right now. But I really want to appreciate the moderator for a beautiful job. We don't thank our webinar enough for the beautiful work they've been doing. But this committee led by Dr. Adeboye has done an excellent job. They don't feature a lot at the forefront, but we know what they are doing and we appreciate their good work. And on behalf of YNNF and everybody here today, I say a big thank you to them. Again, our presenters, beautiful job. Our professors, senior trainers, and our senior faculty for the day, Dr. Badejo, we appreciate your presence. To avoid going through everything that Dr. Ned has said again, kindly permit me to acknowledge every appreciation that has gone out to everyone here present. Let me just extend this to our international participants, members of CANS, young CANS, who usually make it a date with us. Thank you for being here again, for encouraging us, and for contributing, and for making this discussion pretty robust. We look forward to another outing again next month, by God's grace. And we hope it to be an interesting session yet again. So I'll just hand over to Dr. Adeboye to round up, head of webinar committee. Dr. Adeboye.
Yes, thank you very much, Dr. Guga. I think it's been a wonderful evening. As faculty has said, can have a very beautiful surgery, very beautiful management of a patient, but sodium abnormality just mess up the whole work. And as Professor Kano has said, it's often neglected. Most people don't even bother to talk about it, but it's actually something that we always haunt us if we don't take care of that. So, and you can see the amount of discussion that has come about it, and you can see that we have taken a step forward in getting what we thought wasn't available, hypertonic saline. So, I think today webinar has enriched us and has developed our practice. I want to especially thank Dr. Badejo, in whose hand I came as a neonate in neurosurgery. I started with her, she accepted me to neurosurgery as a neonate. So thank you very much for the peers you are giving unto us, our international faculties and the participants and everyone. Thank you so much. Next month, the last Friday of the month, I think 30th of May, I think, will be another day for another interesting discussion. On this note, on behalf of YNNF ESCOs and the webinar committee, I say thank you very much, everyone.
Thank you. Have a pleasant evening.